The following podcast is part of a certified educational activity titled Extending Innovation from Lymphoma to Myeloma, the Next Wave of Bispecific Antibody Breakthroughs for Clinical Care. Access the entire activity and complete the post-test at peerview.com/KQE860. Downloadable slides and practice aids are also available.
Good evening, ladies and gentlemen. Thank you for all coming here today. We have an exciting program. We're going to be talking about extending innovation from lymphoma to myeloma. I'm going to learn what happened in lymphoma so that I can take it home how to treat myeloma. We are going to talk about the next wave of bispecific antibody breakthroughs for clinical care. And I'm Sundar Jagannath, Professor of Medicine at the Icahn School of Medicine at Mount Sinai in New York. With me are two colleagues, Sabarish Ayyappan, Associate Professor and Director of Heme Malignancy at City of Hope, Atlanta, Georgia. Yes, City of Hope, Atlanta, Georgia. And Jennifer Crombie. She is from Harvard Medical School, Dana-Farber Cancer Institute from Boston. So to start off, I would have to say, in multiple myeloma, patients who have recurrent disease after they have been exposed to the three classes of drug or triple class exposed and subsequent relapse. So the triple classes in myeloma are immunomodulatory molecule, proteasome inhibitor, and an anti-CD38 monoclonal antibody. If those patients have been exposed and subsequently have a recurrent disease, then their median progression-free survival is about a year. So you could say 10 months. But if they have been exposed to all three drugs and they have become refractory, whether through the two proteasome inhibitor, two immunomodulatory molecule, and an anti-CD38, then it'll become penta. But once they've been exposed to the three classes of drug and they have become refractory, then you can see the progression-free survival from 10 months drops down to 6 months range. So we really need better therapy for these patients, and this is where we're going to say whether immuno-oncology is promising for these patients and what is the role of the bispecifics. Likewise, we are going to, during the modern era of rituximab era, the outcomes were poor in relapse and refractory diffuse large B-cell lymphoma. The pooled median overall survival for refractory disease was 6.3 months. And here we wanted to ask the question, has the emergence of immunotherapy, CAR T-cell or bispecific antibody, changed the picture? And what about response duration and survival shortens after each relapse in follicular lymphoma? So if the patient has already had 2 relapses, is immunotherapy making a difference in follicular lymphoma? So that is the major theme of today's presentation. And let us look at what have been approved and made available for practice at this time. So bispecific antibodies represents a step forward in multiple myeloma. And the regulatory status is there are 2 bispecific, BCMA bispecific, teclistamab and elranatamab, and a GPRC5D CD3 bispecific, which is talquetamab, which are approved for relapse and refractory myeloma patients who had failed 4 or more lines of prior therapy. And there is linvoseltamab, which is in front of FDA for a priority review. And then there is another ABBV-383, which is in clinical trial. Now, bispecific antibodies represent the next step forward in non-Hodgkin lymphoma. You can see epcoritamab, and you have glofitamab, approved for relapse and refractory diffuse large B-cell lymphoma, and mosunetuzumab, approved in adults with relapsed refractory follicular lymphoma after 2 or more lines of therapy. And then you have odronextamab, which is in phase 3 testing. So what is the goals for us today? Hopefully, we will present you the current evidence supporting the integration of emerging bispecific antibodies in multiple myeloma and lymphoma, and to integrate the emerging bispecific antibody options into sequential management plans for patients with relapsed refractory myeloma as well as in lymphoma. With that, I would now ask my next speaker, Sabarish Ayyappan, who is the Clinical Associate Professor and Medical Director of Hematologic Malignancy at City of Hope, Atlanta, Georgia. He will talk about the next steps in lymphoma bispecifics on the move for diffuse large B-cell lymphoma.
Thank you, Dr. Jagannath, for that introduction, and I'm happy to spend this evening maybe educating you all and getting you some evidence where the bispecifics are in this exciting era of lymphoma management. So to start off with, let's look at this case. This is a patient that you might see in your clinic, a 65-year-old gentleman with diffuse large B-cell lymphoma, treated with R-CHOP, goes into remission, and then relapses on the PET scan as a relapsed disease, was then referred for CAR-T and has a good response with CAR-T. And after CAR-T, 6 months after CAR-T, he's then found to have progression, then found to have diffuse large B-cell lymphoma. So now you have a patient relapsing after 2 effective therapies, and what are your options now for treatment? There are multiple. You may want to think about what he's already been through, and what are the efficacious options that he could get the best response and go into a long-term remission. That's what you're trying to aim for. So I think that really comes up. CAR-T is shown to be efficacious in these patients who are relapsed after diffuse large B-cell lymphoma. So is there life after CAR-T failure? What is the agent that is likely to put him into a long-term remission? And then what are the current experience with the approved agents that you might think about? The 2 agents that are being hotly talked about is accredited and glofitamab. And is there evidence for treating post-CAR-T? And then also the evidence with the other bispecific antibodies like elranatamab that are in still clinical trials. So for background, why are we talking about these patients? So these third-line refractory patients, diffuse large B-cell lymphoma patients, as some that are already shown on the graph. And the first graph is the SCHOLAR-1 study that we often refer to for patients with relapsed and refractory diffuse large B-cell lymphoma. They tend to do poorly. The median survival is about 6 months. These are patients who have been primarily refractory or refractory after auto transplant. The responses with subsequent treatments prior to CAR-T or bispecifics was about 30%, and their survival was only about 6 months. They did very poorly. And the second graph actually depicts a retrospective study that was published from a contemporary era, from 2016 to 2021. Patients with diffuse large B-cell lymphoma, they were followed. As you see on the first line is the first-line therapy. About 75% of patients go into cure, but then about 25% they relapse. And as you can see, in the subsequent lines of therapy, patients do poorly. Either their responses are poor, and then also their survival is poor. So there is an unmet need for this group of patients after 3rd or 4th line of therapy that they need an effective agent that could keep them alive. That's what you're looking for. And what about this other group of patients, post-CAR-T? So you've had CAR-T that has been hot topic for the last 6-7 years in lymphoma. That has put about 50% of patients into remission who are doing poorly earlier. But these other 50% of patients who relapse post-CAR-T, they do very poorly. About median survival is only 6 months. So there is really a need for good agents that are going to put these patients into a good remission and long-term remission. If you look at the NCCN guidelines, this is what you come up at. After 3 lines of therapy for diffuse large B-cell lymphoma, you have the T-cell engagers, the CAR T-cell therapy. Then you have the bispecific antibodies, 2 of them which have been FDA approved, the accredited and glofitamab. Then teclistamab, which is a CD19 targeted antibody drug conjugate. Selinexor is an option. Then there are other options which are being listed after 2 lines of therapy, like for example, polituzumab BR or tafasitamab lenalidomide. Or you could consider brentuximab Revlimid if they're CD30 positive. And if they are non-GCB subtype, then you have ibrutinib or lenalidomide rituximab. When I think about these patients in this algorithm keeps changing because of the newer data that you would get. But in 2024, I would think that if they have not been exposed to CAR-T, I would revive and see, could they get CAR-T again? Is there for some reason they could not get CAR-T in the second line? So I would first see if they could get one of the CAR-T products. If that's not possible, then you go down the pathway of thinking, are they CD19 positive, are they CD20 positive? And one of the really exciting agents we're going to talk about, the bispecific antibodies, you could consider them. If they're CD19 positive, you can think about teclistamab, lenalidomide. You do not have that great data in CD19 post-CAR-T, but there have been case series of patients who have been responding post-CAR-T as well. Loncastuximab, similarly, you have some data on patients responding post-CAR-T if they're CD19 positive. So these are the agents that you would think about in this time period. Now, coming to the bispecific antibody. So what is a bispecific antibody? It's an antibody that has a moiety that can bind to two different antigens, either a CD3, which binds to found on the T cells, or the CD20 or a CD19 is another option too in the lymphoma cells. So here in this cartoon, you have the depiction of a CD3 and a CD20 this bispecific antibody can bind to. And when the bispecific antibody is administered, it binds to the T cell on the CD3 and activates it. And MHC independently, it can then cause cytotoxicity and causes tumor killing by, when it's binding to the CD20 in the lymphoma cell. And these are the 4 antibodies, at least, that are currently available. 2 of them are approved, the glofitamab and epcoritamab for diffuse large B-cell lymphoma. And as you can see in the cartoon, again, there are subtleties how they are manufactured and how they are, how they act on the tumor cells. For example, the glofitamab has 2 CD20 epitopes it can bind to independently, and then epcoritamab binds to 1 CD20, or elranatamab and mosunetuzumab to only 1 CD20 epitope. And the odronextamab is actually IgG4 antibody. Now, one thing common to all of them is they all have their FC moiety silenced because they do not want to call fratricide of the T cells. So they are all bispecific with FC silencing that activates the T cells without really causing more ADCC or fratricide of the T cells. The epcoritamab was studied on this pivotal study in relapsed and refractory diffuse large B-cell lymphoma patients who are refractory after 2 lines of therapy. In this pivotal study, they had 157 patients who were heavily pretreated. You can see there they received at least 3 lines of therapy, and 61% were primary refractory, and 40% of patients had received prior CAR-T. If you look at the graph on the right, the bars on blue are the patients who went into complete response. Ones in red are the ones who went to PR. So a good number, almost 60% of patients had an overall response rate, with a complete response rate of 40% was noted. And now if you look at the graph below, most of these responses were durable. So if you look at it, the median, the duration of response was 15.5 months. And if you went into a complete response, the duration of response was almost 20 months. So with this agent, you could get a durable response, not just going into a complete response. The only caveat with this drug is it is given as it was treated like the clinical trial was designed in a way that patients were treated to progression. So patients get continuous therapy till they progressed. In terms of how it's administered, with it, one thing unique on characteristic of the bispecific antibodies is the cytokine release syndrome. So to mitigate that, these bispecific antibodies are administered in a step-up dosing. So as you can see in this table, on day 1, they're given 0.16 milligram dosing, then day 8, 0.8, and then day 15, they get the full dose, the 48 milligram dose. And it is around the day 15, with this specific bispecific antibody, you expect the cytokine release syndrome. So it is advised that these patients are hospitalized for 24 hours to monitor for cytokine release syndrome, so you can appropriately act on that. And then subsequently, if they do not develop any cytokine release syndrome, subsequent doses can be given as outpatient safely. Now, the other approved bispecific antibody is glofitamab. As said previously alluded to, it binds to 2 CD20 epitopes. And this is administered as intravenous formulation. The epcoritamab is given a subcutaneous formulation. That's a difference. And this registrational study, glofitamab was administered again in a very heavily pretreated population, included prior CAR-T exposed patients in this study. As you can see, the response rate was comparable at 52% overall response rate, with 40% complete response. Now, one thing difference about glofitamab is this is given only as a fixed duration. Patients got only 12 doses or 12 cycles of treatment of glofitamab during the study. And if you look at the graph of these patients and the duration of response, even with 12 doses of the glofitamab, patients had a complete response and they maintained the response beyond the period that they were followed. So 18 months was the median follow-up on the study. If you actually achieved a complete response, the median duration of response was up to 26 months. So again, an effective agent that patients were getting responses and were maintaining response at the time of follow-up. And looking at the overall survival is also good. 12-month overall survival is 50%. Again, this is a heavily pretreated third-line population. We saw the Scholar 1 study, how they did poorly. And this population now was doing better. Even some of them were post-CAR-T. Now, looking at the administration again with glofitamab, this is a subtlety again to this one. The patients on day 1 get obinutuzumab a run-in, and then on day 8 with a step-up dosing or with 2.5 milligram. With this drug, unusually patients develop CRS with this 2.5 milligram dose rather than with a 30 milligram dose. So again, with a 2.5 milligram dose, it's advised to admit the patients and monitor for CRS. Now, in terms of cytokine release syndrome and ICANS, which is characteristically seen with this bispecific antibodies or this T-cell engager class, when you look at this tables, the CRS rates are comparable and mostly grade 1 or 2, not grade 3 rates, not as high as you would see with CAR-T. Particularly in the CAR-Ts, you would see higher grades of CRS and higher grades of ICANS. Comparatively with the bispecific class, it has a more manageable safety profile, I would use the term. And again, the CRS is very predictable, it seems to be, with the first full dose with either the accredited or the glofitamab. And again, depending on what sort of formulation you use, for example, the glofitamab being more an IV formulation, the CRS seem to occur earlier, like 13.5 hours, in comparison to epcoritamab, which is given as subcutaneous. You could see it 20 hours at the second day of administration of this drug. And talking about the ICANS, the rates of ICANS were again very low and were mostly grade 1 and 2. And this is in sort of comparison to CAR-T, where you see high grades of ICANS. So when you're thinking about starting a patient with a bispecific antibody, I think these are some of the steps you want to keep in the back of your mind. Important to know what are the monitoring guidelines, which is unique for each of these bispecific antibodies. There is a step-up dosing. Again, it varies for each of these bispecific antibodies, so you want to be familiar with that. Staff training and preparation, I think, is very important. There is a steroid prophylaxis that goes with each of these bispecific antibodies in the step-up phase, which you want to adhere to. And then talking about the antimicrobial prophylaxis, because these patients are at risk for infections. And my colleague, Dr. Cromley, will go into details more of some of the antimicrobial prophylaxis and training and steroid prophylaxis in our talk. Now coming to the hot topic, you have CAR-T and bispecific. Which one would you choose, right? Like you have availability there. It's a tough question, and I think we are still trying to understand which is the better option. I think at the second line, currently you have CAR-T is approved, so I think there's no brainer at that point. You may think about using CAR-T for those patients who are eligible. But coming to a third line patient like ours, who are, in our patient was already exposed to CAR-T, but then you have other patients who may not have been exposed to CAR-T, and then you want to make a decision. I think there are a few things you want to think about. One is CAR-T still has long-term follow-up data, and it's been curative in a subset of patients. The long-term follow-up in bispecific is still awaited. I know I've shown data that it is durable, but I think more long-term follow-up will give more confidence as to how long these responses could last. Second thing would be is when a disease like diffuse large B-cell lymphoma, the disease is progressing fast. You may not have time to get the insurance approval, get the leukapheresis, manufacturing, and all that done. The bispecific is ready off the shelf, ready to go, and it could potentially be administered even in community practices, I think, once you are trained and available to do, versus the CAR-T is still going to be in specialized, BMT tertiary centers where you're going to be doing the CAR-T. Again, the other thing you would want to think about in terms of the patient makeup that you're seeing, if they would be able to tolerate, the rates of CRS and ICANS that you would see with CAR-T. A really older patient, I would think about doing CAR-T versus bispecific, really depending on their frailty and other things. And the last thing would be is the CAR-T is one-time administration and then follow-up versus a with a bispecific, you're looking at maybe long-term treatment in your office. And also sometimes you're talking about ramp up or bridging therapy, and those can be the subtleties that you want to think about in differences. Just putting what we have in terms of data, CAR-T and bispecific at this point of time, as you can see in the second row, the median follow-up, you have good long-term follow-up in the various CAR-T products. It's still early days with the bispecific antibodies. The response rates, again, are slightly higher with the CAR-T products, but I think with the bispecifics, it's pretty good. I would say, 63% overall response rate, or 60 to 50% with the bispecifics. In terms of PFS, not too much, and then overall survival, we still have, waiting on some long-term follow-up data. In terms of the toxicity profile, like I said earlier, it's more safer. Safety profile is better with the bispecifics in comparison to CAR-T with the CRS and ICANS rates. So the thing that might, again, then pop up is like, what if a patient received CAR-T and then can you do bispecific after that? What is their efficacy? Or say, if a patient, for other reasons, ends up getting bispecific, and then can you do CAR-T? So the evidence, at least at this point of time, from the two trials that I spoke about earlier, with the glofitamab and with the epcoritamab, both included patients who had prior exposed to CAR-T, and about 60% were refractory to CAR-T in both the studies. You can see the CR rates of 35% and 35% in both the studies were noted. So groups of prior CAR-T exposure, and you could still have good responses to bispecific antibodies. In terms of the, I think the safety data, it doesn't, it's still a small number subset you're looking in both the trials. It doesn't appear that there's any worsening safety events if you had received CAR-T prior to getting the bispecific antibody. What about, like I alluded to, if you received bispecifics and then you get CAR-T? So this is a retrospective analysis that is just recently published in Blood of patients who received, I think 47 patients received bispecific antibodies and then went on to get various products of CAR-T, axi-cell, Tisa-cell, lyso-cell. And depending on, the various, they looked at even the washout period. Some patients almost had 50 days, after the bispecific that they got the leukapheresis and then got the CAR-T. The response rates really didn't matter whether you had a shorter or a longer washout period. They really reported 80% overall response rate and almost 40% complete response rate in this, refractory patients with diffuse large B-cell lymphoma. And looking at the toxicity profile, again, what they reported in terms of infections or in terms of CRS or ICANS rate really did not matter. And they compared it with another contemporary cohort of patients who just got plain CAR-T, and it really did not vary in terms of the safety events when you did get a CAR-T after a bispecific. Now, what about there are other bispecific antibodies still being studied in diffuse large B-cell lymphoma. One of them is odronextamab. So this is, again, a little unique from the other two bispecific antibodies. It's an IgG4 bispecific antibody with same Fc silencing that is targets the CD3 and CD20 in the tumor cell. This was studied in this ELM2 study where actually initially they noted the patients were developing CRS. Actually, this was pretty well ahead in terms of the drug development when they noted the CRS events. And they actually modified the step-up dosing. The other ones, you could see a step-up dosing on a single day, where here in this clinical study, they modified that the patients were getting day 1 and day 2, day 8 and day 9, and day 15 and day 16 to reduce the rates of CRS so that you do not have patients developing complications and then getting off study. And then after they went through the step-up period, patients then received the full dose, the 160 milligram dose, for 3 more cycles. And if they were then to achieve a complete response, patients were then switched to the 320 milligram dosing. Looking at the response rates, again, overall response rate was comparable at 52% with the CR rates of 32%. And again, looking at these two graphs, you can look at the responses that were durable. The median duration of response was 10.2 months, and if you're in complete response, the median duration of response was 18 months. And then looking at the PFS and overall survival, again, if you look at patients who achieved CR, the median PFS was 20.4 months, and overall survival was not reached in this group of patients. Looking at the adverse events, about 53% of patients developed grade 3 toxicity, and mostly those grade 3 toxicities were like cytopenias. And if you look at the graph on the right, that really depicts what are the TAEs. The CRS was the most commonly one, but CRS rates were mostly grade 1 and 2, very less grade 3. Remember, this is the one they did a step-up dosing that split over a couple of days, which way I think they kind of reduced the grades of CRS. There were some 3% or 5 patients had deaths on the study, which were mostly infection-related, as it's been noted below. And this study was conducted in the height of the pandemic, and being also a global study, there was some infection or antibiotic prophylaxis guidelines were varied over different countries, so that there were more infections noted, maybe in sort of comparison to the other studies. Now, what about the efficacy of odronextamab in the same population, that is the post-CAR-T? This is the abstract Jennifer presented at ASH this year. And this is the only actually dedicated post-CAR-T cohort that have been studied with the bispecific antibody. And about 47 patients post-CAR-T exposed were treated with odronextamab. Again, looking at the response rate, these patients post-CAR-T had an overall response rate of 47.7% and 30% complete response rate. Again, it's impressive in this post-CAR-T population, I think, receiving bispecific antibody. And the responses, again, were durable, and as you can see it in this table. Now, what's going on with the odronextamab in terms of the relapsed refractory non-Hodgkin's population? It's currently being studied in a phase 3, where they are actually comparing it, one randomizing a group of patients to get odronextamab for a year. The other group of relapsed, and I think at first relapse patients, they either get odronextamab for a year, or they get standard of care salvage chemo followed by auto transplant. So really trying to, really question the paradigm whether a patient at first relapse with diffuse large B-cell lymphoma would just need salvage chemo or transplant, or could you avoid that and do a bispecific antibody? I think the results from this will be interesting to follow. What about other bispecifics? And when you're thinking of trying to improve on what you have, you're trying to add on other effective agents. We have like polatuzumab, which are anti-CD79B targeted antibody drug conjugate. So there is data that has been presented at ASH, and I think more follow-up data is being presented at this ASCO as well, of combining mosunetuzumab with polatuzumab. So the overall response rate that you see as single agent in the 50% is they're seeing more like 60 to 70% and better complete response rates. Similarly, with the glofitamab and pola, again, they were able to demonstrate a better overall response rate and efficacy with a better complete response rate as well. Now, coming back to our patient, so like I spoke about earlier, he's a 65-year-old, was refractory after R-CHOP and then CAR-T therapy. So we did list out multiple different options. And I think I've provided you with evidence today. There is bispecific good agent that is efficacious and durable in terms of response post-CAR-T. Again, it is off the shelf with a favorable safety profile. I think with good preparation, it can be given even in the community. And again, there are multiple bispecifics that are being already approved, and there are other, like I mentioned, that the emerging bispecific that may have a future role, including combination therapies. I think that may be the way to go, where you could probably add this on, and this is likely to be moving up front. I mean, it's currently both the bispecifics are approved in the third line. With the way we're seeing the responses, and this could potentially be moving up front in terms of therapy. And that's where the question comes, how do you sequence, whether you would keep the CAR-T for later, or if you have a bispecific off the shelf ready to go, would you want to give that? And you do still have good data that you could safely use a CAR-T afterwards. That will be the question to see, because there's also question of maybe if you do a bispecific and there's T-cell exhaustion, will there be really fit T-cell that you could use? I think maybe my other two colleagues today might be able to give more information to discuss about that as well.
Thank you very much for that excellent presentation. Okay, now it's my honor to introduce Dr. Jennifer Crombie, who's assistant professor at Harvard Medical School, Dana-Farber Cancer Institute, Boston, Massachusetts, and she has published recently a consensus report in Blood, and we are going to all learn from her. Next steps in lymphoma, bispecific on-the-move follicular lymphoma. Dr. Crombie.
Thank you, and thank you for having me. I'm excited to now switch gears and focus on follicular lymphoma, though many of the themes will be the same as we go through the data. And as you heard, I'll spend a little bit of time focusing on the management of the toxicities that are seen with bispecific and try to answer the question of how we can move these drugs into the community setting. So I'm also going to start with a case. So this is a 73-year-old woman with a history of hypertension and diabetes who's diagnosed with follicular lymphoma. So she initially presented with abdominal pain and was found to have bulky lymphadenopathy within the abdomen. She went on to receive 6 cycles of BR and achieved a complete response. Unfortunately, after 18 months, she had evidence of recurrent disease in a biopsy that showed follicular lymphoma. She was treated with R-squared, again responded, though this time 1 year later had symptomatic lymphadenopathy, again with recurrent disease. In this case, she did not live near a CAR T-cell center and preferred not to travel at this time. So I want you to just keep this case in the back of your mind as we go through the presentation, and we can revisit it at the end. But as we go through the talk, we can think about the prognostic considerations for this patient and for follicular lymphoma in general. What treatment options are available in the third-line setting? And if bispecifics are used, what do we need to think about the dosing, the safety, and the specifics of administration? So as we all know, follicular lymphoma is typically thought of as an indolent non-Hodgkin lymphoma that is slow growing. And for many patients, it's been shown that the overall survival can mirror that of the general population, although patients may require periods of therapy throughout their life. The hope is that each of those treatments provides a sustained remission. However, there are a subset of patients, about 20% or so of follicular lymphoma patients, that will experience early relapse of disease. And those patients are thought to be much more difficult to treat and have an inferior overall survival. You can see here in this figure, this was a pooled analysis of multiple studies looking at the different outcomes among patients who experience this early relapse, specifically within 24 months or progression of POD24, progression of disease. And you can see those patients are along the blue line. All patients are in the green line, and then those patients without early relapse are in the top line. And the overall survival is significantly worse among those early relapsers. So it's really this population where we need to find novel treatment strategies. So looking at the third line in the NCCN guidelines, what options do we have for a patient like this? So we have bispecifics, which we're going to be talking more about today. Mosunetuzumab is the only FDA-approved bispecific for follicular lymphoma, though epcoritamab is in the NCCN guidelines, but is awaiting FDA approval. We also have CAR-T, and then there are other options as well, EZH2 inhibitors and BTK inhibitors. So I want to walk through each of the bispecifics that are available for follicular lymphoma. So I'll start with mosunetuzumab. I just wanted to highlight the treatment schedule here. This is an IV infusion. Like the other bispecifics that we already heard about, there's a step-up dosing where to mitigate the risk of CRS. And this is also a fixed duration therapy where patients either receive about 6 months to a year of therapy, depending on their response after 8 cycles. And so this is the data from the phase 2 study of mosunetuzumab. And there, as you can see, this was a heavily pretreated patient population, high-risk patient population. The majority of patients had more than 3 lines of therapy, And you can see there that about half of patients had POD24. And so even in this higher risk patient population, the overall response rate was 80% with a 60% CR rate and a median progression-free survival of 17.9 months. Among the patients that did respond, there were patients that had sustained responses. And so I next want to talk about the safety of mosunetuzumab. This is a generally well-tolerated bispecific, though as we've been discussing, there is a risk of cytokine release syndrome, and this occurred in this trial in 44% of patients, but most were low grade, with only a few patients having grade 3 or higher CRS. And I didn't mention this, but these hospitalization was not required for patients treated with mosunetuzumab in this trial, though just over 20% of patients did ultimately require observation in the inpatient setting. So in this table, you can see the step-up dosing that is used, and the highest risk of CRS occurs on cycle 1, day 1, and cycle 1, day 15. So next, I wanted to talk about epcoritamab, which I mentioned is in NCCN guidelines. So this was the phase 2 study of epcoritamab in relapsed or refractory follicular lymphoma. There were over 120 patients in the follicular lymphoma cohort, and similar to the population we saw in the mosunetuzumab trial, it was a more heavily pretreated patient population with a large subgroup that fell into this POD24 category, about 42% of patients, and most patients had advanced stage disease at the time of treatment. And here you can see that there was also a high overall response rate of 83% with 63% CR rate and a median progression-free survival of 15.4 months. And in these this bar graph here, they are breaking out the responses in the different patient populations, POD24 patients refractory to their last line of therapy. And you can see that the responses are similar across these different subgroups. Epcoritamab is slightly different. You heard already that this is subcutaneous dosing, when used in follicular lymphoma, there was also a hope to get this drug into the outpatient setting. So there was a cycle 1 optimization where they incorporated in an additional step-up dose, and also there's steroid prophylaxis for a few days after treatment and additional hydration. And so I believe that additional patients on this strategy is going to be presented at ASCO this year. But here you can see among 50 patients treated with this strategy, there was a reduction in the rates of CRS, with less than 50% of patients experiencing CRS, and mostly grade 1. And so with this change, inpatient administration was not required. And then I also wanted to mention odronextamab, which has been studied in relapsed refractory follicular lymphoma in the ELM2 study. Also about 50% of patients who fell into this early relapsing cohort. And as you saw for DLBCL, there's also split dosing that occurs during the step-up dosing period. So treatment occurs on day 1 and 2, 8 and 9, 15 and 16. And ultimately, patients do step up to a slightly lower dose than is used with diffuse large B-cell lymphoma, but it is similar. And so here you can see the baseline characteristics. Median prior lines of therapy of 3 and 128 patients were included. So among this more high-risk patient population, the overall response rate was 80.5%, and the CR rate was 73.5%. And the median PFS was over 20 months, and was better among patients who achieved a CR with some durable responses. The odronextamab was well tolerated. About 50% of patients experienced CRS, primarily low grade. This study, like some other bispecific studies that were conducted during the height of the COVID-19 pandemic, did have high rates of infection. So how do bispecifics compare to CAR T in follicular lymphoma? It's the same theme. The bispecifics seem to have a better safety profile with the cost of having a slightly inferior progression-free survival. So in this table, you can see the outcomes of the 3 bispecific products compared to the available bispecific agents. So I next wanted to talk about how we can move these agents safely into the community. It sounded like, based off of the survey that was asked in the beginning, this seems to be an important question for many of you in the audience. And so because many providers felt the same way, that there wasn't a clear direction on how to manage the toxicity of bispecifics, and many centers don't have experience using CAR T, that they were looking for advice on how to deal with the CRS if it were to occur. And so there was a group effort. This was a collaboration that was sponsored by the Lymphoma Research Foundation. Providers from really across the world, and both in the academic and community practice setting, got together to talk through our experience with bispecific antibodies and try to put together some consensus recommendation for how to deal with toxicity, acknowledging that this is a new type of therapy and that the guidelines will obviously evolve as we all gain more experience with them. So this was a schema from the paper that was recently published, and it talks just about the various steps that go into thinking about management of toxicity. The first key point is to think about the patient in front of you that you're treating, thinking about the amount of disease that they have, their performance status and frailty, and how close they live to the hospital, their social support, all the patient factors. Patient education is key for bispecific antibodies. Patients need to be aware of what toxicities may arise and when to call. The practicalities of drug administration. Can this be done in the outpatient setting? Do patients need to be observed in the inpatient setting? Then once they do receive the drug, how should we be monitoring them? And then lastly, and most importantly, if they do develop the toxicities, what should we tell them to do, or how should we manage it? So in this paper, we did provide some examples of education or information sheets that can be administered to a patient, and every center might have something different, but this could be a starting point, just highlighting to the patient what things to be looking for, when to call, and just to make sure that there's a clear line of communication between the patient and the treating team. And so if you wanted to see that, I would encourage you to look at the paper if you wanted to print that out. And so I think it's helpful to first think about what are the pre-treatment steps. So before we actually treat the patient, have a plan in place. And so I already mentioned when going through the schema that we want to think about the patient and their comorbidities and disease burden. And then also make sure you have a plan in place. So where would you send them to the hospital? Can the hospital that's treating the patient accept the patient, or do they need to go to a nearby hospital? Do they have tocilizumab available? Some practice sites, the providers treat multiple different types of cancers. They treat solid tumors and heme malignancies. So I have heard from practices like that it can be beneficial to identify key providers that may be more comfortable with bispecifics or have a focus that may be more familiar at dealing with these issues, and then obviously educate the emergency room staff who may be receiving these patients. And then I think I really already mentioned this, but education to the patient is important. And then think about how they can monitor their vitals at home. So are there any ways that patients can be provided a blood pressure cuff, because that may be important information to have if a patient does call you with a fever, to know that they're hemodynamically stable. So I just wanted to walk through in the guideline or the consensus recommendations that were put together, how to think about management of the toxicity. And there's much more detail in the paper, but I just wanted to point out some of the highlights. And so one of the more controversial ones is how to manage grade 1. And this was done really differently among the different providers. And so I think overall, people did feel comfortable treating grade 1 CRS at home and managing patients with Tylenol, recommending oral hydration, and with close monitoring of their home vitals. However, we wanted to make sure that people were aware that if they had a fever, a recurrent fever, particularly if it was immediately after Tylenol, that might be a patient you'd want to give dexamethasone to, although continued observation would also be reasonable. We also discussed as a group the comfort of giving patients steroids to take at home with instructions over the phone. People had different opinions on that, but it would be a reasonable strategy to allow patients to take dexamethasone potentially even before coming in for evaluation. And then if patients have ongoing symptoms, daily dexamethasone would be reasonable. It is worth noting when going through these recommendations that the bispecifics are a little bit different, and some include daily steroids as part of their prophylaxis management during the step-up period. So those patients may have to be thought of as a little different. If you are having persistent fevers despite the prophylaxis with steroids, that might be a patient you'd want to bring in sooner. And then tocilizumab could be used with protracted symptoms. And then, again, always important to remember that the patient comorbidities are key. The age of the patient is important. There may be patients you want to give earlier tocilizumab and dexamethasone to if you're worried about them. Grade 2, these patients should be, according to the group, felt that it would be helpful to be evaluated in person. Most patients would have to go to an emergency room given that they would have low blood pressure, though there are some infusion centers that may have the capabilities of managing these types of side effects. These are patients you'd want to give dexamethasone to. And there was a recommendation from the group to trial steroids first, knowing that tocilizumab may not be as readily available at all centers and may not be covered by insurance. So try steroids with a low threshold to add in tocilizumab if patients have persistent symptoms. And then grade 3 and 4, by definition, these are patients who are hemodynamically unstable and requiring more intensive management to support their blood pressure. So it's more clear cut that these patients would be in the hospital, likely in an ICU setting, but we do give guidance on how to use what steroids and other anti-cytokine therapy that could be used if it was helpful to reference. So thinking about moving these into the community, these are just some things to consider and how to navigate this step-up period. So one potential strategy could be to collaborate with a larger center that is more familiar with the step-up dosing, and then have the patient continue their therapy after at their local institution. The risk of CRS is very low after the step-up, or really not seen at all after that step-up period. I mentioned the kind of creation of people more familiar with the side effects and collaboration with other nearby treatment facilities. We also, in this consensus guideline, wanted to highlight that neurotoxicity is rare with the bispecifics, CD20, CD3 bispecifics, so it was not felt like driving restrictions were necessary for patients who felt well, although we're used to following what we do for CAR T with bispecifics, so we don't necessarily have to follow those same recommendations. And patients don't necessarily require ongoing neurologic monitoring if they're feeling well. However, there have been very low rates of ICANS reported in the context of trials, so it is still worth knowing how to grade those patients and what to do. Those patients should also be considered for alternative causes. So in the paper, we do mention typical management of neurologic toxicity and the tables on how to grade them. And so another issue that has come up using these antibodies, bispecific antibodies, are infections. We've seen throughout the trials during the pandemic that there were high rates of COVID-19 and COVID-19 associated mortality. So this is an issue, and particularly in patients who may be on indefinite therapy. And so it's worth noting that those patients have to be managed with caution and potentially seeking out the advice from infectious disease colleagues. And also, like we do with CAR T, monitoring for hypogammaglobulinemia with monitoring of IgG levels and IVIG therapy for patients with recurrent infections or low levels. It is recommended that patients be on PCP and BCP prophylaxis. These are by definition, heavily pretreated patients. And so given the infections that were seen across the trials, it was uniformly felt that these should be recommended. We said for at least 6 months, though this may vary by practice. And like any B-cell targeting therapy, thinking about reactivation of viral infections. So just very quickly, I want to talk about the next steps in follicular lymphoma. Just like large cell lymphoma, these started out as single agents, but now we're seeing these bispecific antibodies being used in combination. We saw, although there hasn't been a lot of follow-up, we have seen epcoritamab being studied in combination with R-squared in relapsed refractory follicular lymphoma with an overall response rate of 96%, and a very high CR rate. So we'll need a longer follow-up on this study. Odronextamab is also looking at combination therapy. So there's a study right now comparing odronextamab in combination with lenalidomide as compared to R-squared. So we'll await the results of this trial. And bispecifics are also moving to the front line. So we're seeing studies now with epcoritamab plus R-squared in the front line, which small numbers to date, but favorable or encouraging overall response rate in early data. And then there's also 2 ongoing studies of odronextamab in the front line for follicular lymphoma. And these are both randomized studies, odronextamab alone compared to rituximab with investigator's choice therapy, and then another study looking at odronextamab in combination with chemo as compared to chemoimmunotherapy. I just will highlight 2 other frontline studies. These are studies that we have open at our institution looking at glofitamab plus obinutuzumab in the frontline, as well as epcoritamab plus rituximab, so kind of chemo-free strategies. So with that, I wanted to kind of revisit our case, and kind of go through some of the take-home points from this talk, which is that bispecifics are approved in the third line and would be a reasonable option for a patient like this who did not want to travel to a CAR T-cell center and is in need of third-line treatment with high-risk disease. And so emerging, and then also the bispecifics are going to be important in the community where patients may not want to travel. This could be an off-the-shelf option that they could receive closer to home. And then lastly, there are multiple studies ongoing that are looking at combination strategies as well as moving the bispecifics up to earlier lines of therapy in FL.
Thank you very much, Dr. Crombie. Now let's see. Okay, now we'll go into the next steps in multiple myeloma, the coming wave of PCMA. So we saw lymphoma. Let's see what what am I going to do in myeloma? So here's a patient, 8 years old, Scott, originally presented with high-risk multiple myeloma. High risk because he had 1q21 amplification and, of course, deletion 13 and plus 11. The treatment history, the patient has received daratumumab, so anti-CD38, had received Revlimid and pomalidomide, so 2 immunomodulatory molecules, Velcade and carfilzomib, the 2 proteasome inhibitors, so this patient is penta-exposed. And finally, when the patient had progression of disease, even received selinexor, carfilzomib, and dexamethasone, achieved partial remission just for 2 months, and then started progressing rapidly. So what are the points to consider here? Is it too late for CAR T, either because is it too late because he's old, or is it too late because the patient has a rapidly progressive disease and he has not already been referred to a center? So that's a pun there. Is it too late for CAR T? Can you wait? Is there a role for BCMA bispecifics and BCMA or another antigen, GPRC5D target, and emerging BCMA bispecific? What will their role be? So let us see whether I do as good a job as my lymphoma colleagues. What is the current experience with established BCMA bispecifics? So here, the BCMA bispecific, the BCMA B-cell maturation antigen is expressed highly in the plasma cells, and the CD3 binds to the T cells. And there are 2 different bispecific. One is the teclistamab, and the other one is elranatamab, which is a humanized bispecific antibody. And then you have GPRC5D, which is expressed highly in the myeloma cells and few extra areas in the body, like epithelial cells in the skin and the nails and the tongue. And here, the CD3 and talquetamab. So you have these 3 drugs which are there. So what does the NCCN guidelines recommend for bispecific antibodies? So all of them should have failed 4 prior therapies, including the anti-CD38, antibody, proteasome inhibitor, and the IMiD. And you have elranatamab and teclistamab. Those are 2 anti-BCMA bispecific, and talquetamab, which is targeting the GPRC5D. So what are the supporting evidence? For the elranatamab, this was the Mechanism 3 trial, and overall response rate was 61%. And even in patients with prior BCMA exposed, these were all BCMA ADC, not a BCMA bispecific. BCMA ADC, or they could have had a CAR T. So even if they had prior BCMA ADC exposed, the overall response rate was still very good at 46%. And the median progression-free survival was 17 months. What about teclistamab? Again, you have a robust overall response rate of 63%, and the patient who had BCMA ADC exposure, they still responded very well, 59%, and the median progression-free survival was 11.3 months. So what about step-up dosing? This is a principle which is used across the board. You heard it in DLBCL, we heard it in follicular lymphoma and bispecific, and now in multiple myeloma. Again, there is a step-up dosing. The whole idea is to start with a homeopathic dose and escalate it a little bit more, and then finally give the full dose. And thereby, if they are going to have CRS, it'll be milder, so you can manage it much better, so nobody gets a severe reaction. So there is step-up dosing here for teclistamab, day 1, 4, and 7 with the doses. And then subsequently, the dosing was weekly. And then for patients who achieved complete remission or better, they were, bi-weekly dosing was done. When these studies were done earlier on in multiple myeloma, as you know, it is not a curable cancer, and always continuous therapy was important. So the studies were designed, that they would continue with the bispecific antibody. They were not fixed duration. So what about the safety profile? You could see that the infection was very high, 78%, and mainly respiratory viral infections, 56%. And in the COVID era, there were 27% of the patients had COVID-19 and other viral infection. But there was also pneumocystis carinii, or now it is called PJP, pneumonia, Girovici. So you could see that infection is important. And CRS is also there, 72%. But you see that only 0.6% had grade 3. This is almost like what we heard in diffuse large B-cell lymphoma and follicular lymphoma. So high-grade CRS is very uncommon with bispecific. Other consideration, ICANS has been reported in 3% of the patient. And of course, the BCMA bispecific do cause cytopenia, especially neutropenia. That should be kept in mind. Now, what about elranatamab? Here again, there is a step-up dosing here. And then they go through weekly dosing. And then they go through biweekly dosing from week 25, 6 months onward, every 2 weeks thereafter. Again, this was designed at a time. The question was not whether we can stop. The question was continuous therapy until they progress. So that's how they were designed. What about the safety profile? Again, the infection, BCMA-directed bispecifics have a high infection rate, 70%. CRS rate, you can see 58%, no grade 3, 4 CRS. ICANS was reported in 5% of the patient, but monitor CBC, not periodically, I would say regularly, because neutropenia is important, and we already know BCMA bispecific wipes out the plasma cells completely, so they can't make antibodies. And it is also somewhat deeper into the B cell. So it is immunosuppressive treatment in myeloma patient, and that should be kept in mind. So key points for infection management with BCMA bispecifics are preventive protocols are key, and then PJP prophylaxis is important, especially if the helper T cell count is below 200. We learned this from HIV days. So you can check out the CD4 count and immediately implement PJP prophylaxis. We don't want to reinvent the wheel. And of course, in myeloma, we always use acyclovir prophylaxis or, so viral prophylaxis for HSV and VZV is important. And we do recommend IVIG supplementation because you saw high infection. Dramatic response, deep responses, 63 to 70% of the patient respond. And majority of the response of VGPR are better. You don't want your patient dying from infection. So principles of choosing between bispecifics and CAR-T and evidence for sequential care. So while the clinical trials were conducted, there were patients who had, relapsed, sequencing BCMA platform. So you could use BCMA for CAR-T relapse, or you could use CAR-T for BCMA relapse. I will show the principles in the next slide. But what you see is the overall response rate is over 50% by either way when you do it. But the timing is also important. So is there a response? Can you use BCMA bispecific after CAR-T failure? Yes, you can. Can you use, CAR-T after a bispecific? Yes, but not necessarily immediately after a BCMA bispecific. And we'll look at that. Why? This principle will be true across the board, okay? So post-bispecific antibody therapy, you see bispecific is given continuously until progression in myeloma. So what is happening? The relapse is on therapy. And so how do they relapse when they are getting this drug regularly? Why are they relapsing? Then we have to see there are two mechanisms. Either the tumor antigen is downregulated or mutated, or there is T cell exhaustion or upregulation of Treg. So if that is the case, if the patient is progressing on BCMA, the CAR-Ts that are approved are BCMA CAR-T. Do you want to do a BCMA CAR-T in this patient? You would fail. First of all, you may not get good T cell collection, it may fail, because one of the reasons we think it fails is because there is a T cell energy or exhaustion or upregulation of T regulatory cells. Or the BCMA could have been mutated or downregulated. So you need to keep in mind, you cannot go right away, but you can give interim therapy in between something else, and then you can consider CAR T, like an salvage auto transplant. We collected stem cell in all the myeloma patient, and the patient never went through transplant. You have your stem cell stored. The next thing is post-CAR T failure. So these are patients who have relapsed off treatment because it's one and done deal. If they relapse especially late, first of all, the relapse is off treatment. Later the relapse, better the T cell function in them. And the BCMA is still expressed in majority of patients. You will get case reports from Harvard or Germany about how they discovered a patient in which the BCMA was lost. But it is case report from the center, but not the majority of the patients. And retreatment with bispecific is also, very successful in these patients because of that. And you can even use the BCMA bispecific in a BCMA CAR T failure patient, especially if the relapse is late. So that is the difference, and this principle is true even for lymphoma. Preparing for next generation of BCMA bispecifics. Okay, so linvoseltamab, as I said, is right now under the FDA for priority review for approval, and then there is ABVV. And cevostamab, this is yet just like talquetamab, which was against GPRC5D, a different target on the myeloma cell. You have cevostamab, which is FCRH5 as the target, and CD3 humanized. So this trial was actually done with fixed duration, and this showed that once they achieve complete remission MRD negative, the responses are quite durable. So we'll talk about linvoseltamab because it is right now in front of FDA for approval. It is a BCMA CD3 bispecific antibody. It's again a fully human bispecific antibody. And the results are, which I had the opportunity to present in AACR, you could see the overall response rate is almost 70%. And 40% of them, or close to 40%, had achieved complete remission or better. And among those complete response patients, when the MRD data could be done, and then you find out of the 37 patients, 50% of them were MRD negative at 10 to the minus 5 or 10 to the minus 6 level. So that is important to keep in mind. Again, there is a step-up dosing. It is slightly different. It's given once a week, until 14 weeks. And the first week they get 5 milligrams. Second week they get 25 milligrams. There is a 24-hour hospitalization. And then afterwards they get the full dose, but they are not hospitalized because majority of the CRS is during day 1 or day 8 of the step-up dosing. What about the safety? You see that the most of the CRS occurred during week 1, first dose, when they got the lowest dose, 5 milligram priming dose. And grade 3 CRS is very uncommon, as you can see in most of these patients. What about infection? Yes, this is again a BCMA bispecific antibody. Plasma cells are completely wiped out, the good, the bad, the ugly. So they don't make any antibodies. IgG, IgA, and IgM are very low. And these are myeloma patients, so they are prone for infection. But in this particular study, by design, as soon as the patient achieves CR or VGPR at the end of 6 months, they were all given once a month. The infection rate came down dramatically. So this was a trial to show you that you can reduce the infection rate by reducing the frequency in those patients who had achieved CR and VGPR. Even on the prior trials, magnetism trial or teclistamab, you can change how you use it because the principle has been established here. ABBV 383, is another BCMA bispecific antibody. It was uniquely designed to bind less tightly to CD3, hoping that the CRS side effect will be lower without compromising on the overall response rate. At the 60 milligram dose, you could see the response rate are, 60% overall response rate, and majority, over 50%, is VGPR or better. So the responses to bispecific, one of it is classic, is it's very deep responses. That should be kept in mind. So revisiting our patient with high-risk triple-class refractory myeloma patient, we go back to this patient. For this patient, he had an aggressive relapse. So now sending him to prepare CAR-T with a 2-month wait would not be ideal, and he is already penta-refractory. So how to manage him till the CAR-T is ready is going to be a challenge. So you should be able to go directly for a bispecific. This is an effective treatment option, particularly since the patient is BCMA naive. And understanding the principle of delivering the bispecific, which we talked about, step-up dosing, etc. And there is also in myeloma, you have different target. You have GPRC5D talquetamab. So some patient, you can give the talquetamab, you can still keep the CAR-T in reserve, BCMA-directed CAR-T in reserve. So it is also still available, especially in myeloma, because you have a different target that is available. Okay, so now we can use the question answer. So there are a few questions up here, and I'll go through them. So first one is in non-Hodgkin's lymphoma. Are there any non-Hodgkin lymphoma patient for whom you would always recommend hospitalization during step-up versus outpatient? Dr. Crombie.
So I don't think there is probably one characteristic that I would say always for. However, there are some key things that I would look for in a patient when making that decision. The big ones are the patient's kind of looking at their comorbidities or overall frailty. I recently treated a patient who is in their 90s with epcoritamab for diffuse large B-cell lymphoma, and that was a patient I was, even for the first dose, where it's not required or suggested per the label that they be admitted, I decided to admit him because of his age and frailty. So he did quite well. Maybe I didn't need to do that, but I think it's always better to err on the side of caution if you're worried about a patient. There may also be patients with other like organ issues that make you want to give a dose in the inpatient setting, but I don't have any strict age or strict criteria that I would use. I don't know if you have any different thoughts.
I think I agree. I think the patient characteristic is more important. If an older patient, maybe with frailty, is somebody, and maybe caregiver status, I think that would be important to see if they're going to be alone, and maybe better to be monitored, because you can't be, you have all the thermometer and the blood pressure monitoring, but if they are alone and they're actually getting sick, that may be an issue. Occasionally I may think about somebody maybe with some circulating disease, if they have any follicular or mantle cell. Those are the patients I may think they may have high risk for CRS, and may think about getting step-up to monitor more inpatient than outpatient.
That's a very good point. Even in myeloma, plasma cell leukemia is a serious case where you get a severe CRS. So that's important. Now, Dr. Ayyappan, any rationale for combining CD19 monoclonal antibody with CD20 bispecific to target both antigen?
I think there are ongoing studies with combining. I think they're looking at either the bispecific antibody targeting the CD20, and then you have CD19, maybe you have different agents. They're looking at combining that, and I think maybe ISCs, that's what I've heard about. It'll be a question of whether the patient's already been exposed to maybe CAR-T, and it's only CD19 CAR-Ts. But there are also other antigen CD22, CD79B, and other things that you can also target, and potentially we're looking at, enough of investigators, we're looking at trying to combine different agents, efficacious agents, to try to improve on the efficacy.
Yeah, I don't know about combining the monoclonals together, but I am aware of the bispecifics being combined with other CD19 direct therapies. So I think there will be a role for combination strategies for bispecifics. We saw high response rates when used with other agents.
Take. So next is a general question.
That's a microphone.
Oh, good.
Lymphoma myeloma physician in Cincinnati. I practice in a hybrid community practice. We started myeloma, teclistamab, talquetamab. I see a lot of toxicity with talquetamab, skin toxicity and nail changes. How you manage in your practice? You change them to every 2 weeks protocol or how? And also the appetite and malnutrition is another. So what is your strategy managing?
Okay. Very, very good question. I did not touch on it because this was BCMA, but I'm happy you asked that question for talquetamab. So as I said, the GPRC5D is expressed in epithelial cells in the nails and in the tongue. So there is dysgeusia, then hair follicles, so you would have skin rash. So those are toxicities. But the nail toxicity, we ask them to use a lot of ointments and salve because it looks terrible, but usually if the patient is having excellent response, they usually tolerate it and the nail completely comes off. So they are actually even denuded of nails in their fingers. So that has not been. But the other one which you said about dysgeusia and weight loss, that is quite serious. So usually bispecific patients, they respond very quickly. So first of all, you know within a month, are they responding or not? Right now, you are allowed to use it after 4 lines of therapy, after 3 classes of drug exposure. So this is literally unmet medical need. So if you don't give this life-saving drug, which could put them into complete deep remission and bring them into, and responding patient, the median duration of response is 2 years, right? So it is a balance. But if they do develop dysgeusia, then you have to back down on the dosing and the frequencies. So, at 400 milligram of talquetamab, it's supposed to be weekly, 800 milligram every other week. But clinical trials, that's my pet peeve. Clinical trials have to be done very uniformly, multi-center across, so that the FDA can adjudicate and approve the drug. Once the drug is approved, we are going to be clinician at the bedside. Our patients are not necessarily clinical trial eligible. Clinical trial, 10% of the patient participate in clinical trial. They don't have renal impairment, they don't have comorbidities, so many things are there. So I feel compelled to say that at the bedside, you'll have to look at the patient's clinical situation. And as I said, these remissions, they are deep, they don't relapse right away. So you can stagger, give it at 4 weeks later, So they have a dramatic response in the first month because the nail changes won't happen within the first month because the nail grows in the hand 6 months to go from one end to the other and 12 months in the foot. So the nail is not the problem. You can find out whether the patient is... Dysgeusia would be a problem. At that time, you need to make sure you maintain the nutrition, ask them to take supplements. If they are not able to eat properly, make sure they are hydrated, cajole the patient. They will see the response and they will tolerate it. But after a while, once the weight loss and other things, that means they are not able to follow, you suddenly back down after 1 month. The studies are all, as I told you, it has been designed, it is done 6 months. So this is my personal opinion, not evidence-based medicine, because I'm standing here and supposed to say what is evidence-based medicine. But we are physicians. We have been trained. We are taking care of physicians. I cannot be deprived of being a physician at the bedside. So that is what you should do.
So I do every 2 weeks now with my patient. Have you done like now, or the patient which I'm treating currently is on talquetamab and is doing well. But have you tried MRD-directed approach?
Yes, we do that routinely from newly diagnosed because I want to cure myeloma. You can cure even newly diagnosed myeloma. I'm the only one who will be saying that, but that's not evidence-based, they will say. But anyway, the goal now with the number of chocolates in the box, as I say to my patient, our goal is to see how I can cure you. And one of the steps is how deep is the remission, how long I want to maintain it. So I do need to get adaptive technology, FDA approved, when I'm doing the diagnostic bone marrow, also send it to that so they can have the probe available. Later on, when you want to find out how deep it is, you didn't have to do it. This cannot be in academic medicine. This cannot be only in trial. You are taking care of the patient. I want your patient to be cured as much as a patient in an ivory tower. So these are the only things they end up doing to find out how deep the remission is. And they publish MRD is related with the survival. If it is, then you should incorporate in your practice. That also able to tells you how to reduce the frequency, how to manage the toxicity. It gives you confidence.
Thank you.
Any other question from the audience? Okay. Then let me go to, after I'm told all the non-evidence-based personal opinion, let's go back to some evidence-based answers from my colleagues. Is it possible to modify the step-up dosing with EPCOR? I don't know what the full name is. EPCOR, if CRS is unexpectedly severe or particular concern. Who is the EPCOR expert? Okay.
I mean, I think on the, at least going by the clinical trial guidelines.
Yes, you better stick to it. I'm an old man. I go by my experience and I value my experience.
And with the experience, I would say that if a patient were to develop severe CRS, you would treat the CRS and make sure they recover. You could, as long as they're back to their normal organ function, I would go back and re-challenge them, but probably monitor them closely, and you could still treat them again. I've had patients who developed CRS, went to the ICU, came back, and then we put them back on the EPCOR study, and they continued back on the study. So it is possible. But you have to wait for the CRS to completely get better. And patient, obviously, with such severe CRS is going to take a while to recover. After recovery, you can re-challenge them again.
Yeah, same. And you might want to, just like you said, repeat that dose.
But let me ask you, all the studies, evidence-based, okay? CRS is happening during the first and the second dose or the step-up dosing. Afterwards, they're all getting it. It doesn't happen. The CRS happens to be serious, of course, but you get over. But they're not going to get the CRS again. So I don't see why not. But you can always reduce the dose, which is not evidence-based. But you can always reduce the dose, and you can give tocilizumab and move forward.
We don't typically do a dose reduction, but it's just continue on with the ramp up, because that's when you're likely to see it. So I think the goal would be to get that patient passed through that hurdle. But monitoring them in the inpatient setting would be a good idea, because it could happen again. So,
since you have a lot of experience, and I don't in lymphoma, in myeloma, extramedullary disease, bulky disease, the bispecific and CAR-T don't do well. They relapse back. And the explanation is like solid tumor, that they are not able to penetrate and they don't home in. In follicular lymphoma, since your case you presented was a bulky abdominal disease, how do bulky diseases in follicular lymphoma do on bispecifics?
I think there is a concern that those patients do less well with the bispecific. That may be a type of case where a combination strategy may be more beneficial. But yeah, I think that is something we would worry about. Same with diffuse large.
Okay, yeah, I think responses specifically may not be, as long as they're responding in lymphoma, I think they do respond pretty well. The question of whether they can relapse, and CRS, also with bulky disease, maybe you could have that.
There are one or two questions which actually comes back to you in terms of sequencing. Do you treat most bispecific patients who are CAR-T relapsed? How do you define bispecific eligibility with regards to CAR-T and transplant?
So I think most of if you go back and look at the studies and the ones that we have participated, CAR-T eligibility was 3 months. I think you had to be post 3 months of CAR-T that then patients were enrolled on the studies. Or some studies are even 6 months. So those patients, again, that would be the caveat to take from the talk, which I didn't bring up, is that maybe these patients were actually doing better. But then you have really primary refractory patients that on CAR-T were progressing there. And then you give the bispecific, are they going to respond? And that we've had, at least in anecdotal experience, is not doing very well. So question of how are you going to deal with those patients, that's where I think the bispecifics in combination strategies may be an option to think about. I'm not sure about transplant, but I think probably they're alluding to whether post-transplant again progressing, right?
Myeloma doctors keep giving transplants. We always have stem cells in store.
We are following you and collecting stem cells.
We collect for 2 or 3 or more and keep it there. So
I don't know if they're asking if a patient who you may think is not a transplant candidate would be a candidate for bispecific therapy.
Oh, correct. Maybe.
Sure,
Right.
that.
Oh, why don't you answer that question? If a patient is not eligible for, transplant, so you don't use transplant very much in follicular lymphoma, do you? But this is more for...
So I think in diffuse large B-cell lymphoma, there is still, technically a role for transplant in patients who relapse beyond the 1-year mark in the second line. So those patients still can get chemotherapy and a transplant. Though, as patients get older, you do worry about the toxicity with an auto transplant. We're pretty liberal at our center about giving transplant even to people in their, early 70s. However, we are able to proceed with bispecifics and even CAR-T in patients who may not be a candidate for an auto transplant. So I think we have a growing comfort. I've given even CAR-T to people who are much older than that.
It's almost time to wrap up. The last question is there an age cutoff for CAR-T for you? And do you have an age cutoff for bispecific? So you have bispecific and CAR-T. If an 88-year-old patient comes, would you offer them CAR-T, one and done deal, or you will go for bispecific? What was the answer?
I would probably, for which disease?
88-year-old woman.
FL, I would give bispecific.
Okay, FL, you'll give bispecific. Now that's asking for DLBS.
Yeah. It depends on how he is actually. If he is walking and he's like, maybe
he's walking, but he's 88 and had some comorbidities. He's not
comorbidities. Then
he's not somebody who's going to be sprinting now.
I mean, like if it's, I think the oldest I've done CAR-T is 83. So, a diffuse large B-cell lymphoma patient, and he did pretty good. So if they are active and they have good caregiver status, age is not a cutoff at all. And comorbidities obviously will come in if they have any CKD or anything else, then I would really worry about doing CAR-T. But bispecifics, I'll be a little bit more liberal in trying that with those older patients, even with some comorbidities.
So that's kind of general rule. It doesn't matter myeloma or lymphoma. CAR-T is you give the cells and they expand in the patient and create all the toxicity. Like transplant, we have no control over it. Whereas bispecific, we have a lot more control. And therefore, bispecific is preferred for frail patients and more elderly patients. And also, you can do it right away. Anybody, like my patient who was 80 and who was progressing rapidly, bispecific is the choice. I think, thank you all for your patience, and we should wrap it up, I think.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit at peerview.com/KQE860. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent medical education grant from Regeneron Pharmaceuticals, Incorporated.